After doing a fracture shaft of the femur, let's enter into the knee injury topic, a very important one from the clinical point of view, because knee joint is one of the commonest joint to get injured. Now, in the beginning, let's know relevant anatomy of the knee joint. Okay, so according to the classification of the joint, knee joint is which type of joint? According to the classification, yes,
Hinge joint.
exactly, hinge joint, or you can say it's a synovial joint first, and uh, among the synovial joint, it's a hinge or modified hinge type of joint. Okay, that is knee joint. This is the very basic thing. It is often termed a compound joint having tibiofemoral and patellofemoral component. Now, tibiofemoral means tibia, that is upper end or upper part of the tibia, and lower end of the femur. Okay, they are articulating with each other. This is known as tibiofemoral joint. And patellofemoral, patella, okay, is articulating with femur, patellofemoral component. That's why it is known as a complicated or compound type of joint. So this is a modified hinge joint which permit flexion and extension as well as slight internal and external rotation as the movement. But main movements are flexion and extension. Now, all of you, please pay attention here. See this? This is femur, okay, the lower end of the femur. This is upper part of the tibia. This is known as tibiofemoral articulation. This is a part of the knee joint. Another is patellofemoral. Now this is patella. The patella is cut here. So this is a patella, and this is the surface of the femur which articulates with patella. So this together is patellofemoral articulation. It's a part of the knee joint. What type of bone is patella? In our classification, what we call patella is what type of bone? Anyone?
Sysamoid bone.
Sesamoid bone. Excellent. Sesamoid bone. Very good answer. So this patella actually is a bone which is developed inside this tendon. Okay. Though the ligament term is used here, this is a tendon of quadriceps femoris. So patella is developed inside that tendon. That's why it is known as sesamoid bone. Now let's focus on the different ligament which are present around the knee joint. Right now I want to show you those different structure. These are called meniscus. Okay, meniscus. Meniscus are of two type: lateral meniscus and the medial meniscus. Lateral and the medial. See there. Okay, so this is a fibula bone. So structure which is present towards fibula is the lateral one, and another is a medial one. So this is lateral meniscus. Here is the medial meniscus. Another important ligaments is here. You can see this one. Okay, on other side also. Can you name what is this ligament? Just remember the name of the bone there. Your answer is right. Which ligament is this?
Lateral collateral ligament.
Excellent. And this is
Medial collateral ligament.
medial collateral ligament. Excellent. So this is lateral collateral ligament, medial collateral ligament. Sometimes we also call this fibular collateral ligament and tibial collateral ligament. Okay, fibular and tibial, because fibula is on this side, tibial on this side. Okay, so that's another one. And third, very important types of ligaments are called cruciate ligament. They are present inside the knee joint itself. They are anterior cruciate ligament and posterior cruciate ligament. So let me take this name again: medial meniscus and lateral meniscus. This is lateral collateral ligament and medial collateral ligament, or fibular collateral ligament and tibial collateral ligament, anterior cruciate ligament and posterior cruciate ligament. And one more, which is actually not the true ligament. This is called patellar ligament. Okay, or ligamentum patellae. This is actually the tendon of quadriceps femoris muscle. Let's move on. So here is another slide which is telling us about the relevant anatomy of the knee joint. So this is the diagram of the right tibial plateau, means the upper part of the tibia. Okay, now see there, once again the same structure which I told you are written there. Posterior horn of lateral meniscus. 2 is anterior horn of lateral meniscus. This is a medial meniscus now. This is a medial meniscus. Okay, so anterior and the posterior horn, and these are the cruciate ligament. Okay, these are the cruciate ligament. This is posterior, here is anterior. Number 4 is anterior, and number 3 is posterior. So this is the one of the main anatomical slide. Another one, just now you have seen. Let's repeat once again. This is ligamentum patellae or patellar tendon, and patella is present inside that. That's why it is known as sesamoid bone. Okay, so this is lateral collateral ligament. Here is a medial collateral ligament. This is medial meniscus. Here is a lateral meniscus, and inside the knee joint we have anterior cruciate ligament and posterior cruciate ligament. Now, another important part of this lecture is how to evaluate the knee joint. What are the main problem in the knee joint, or what are the main complaints from the patient side, and as a doctor, how do we evaluate the knee? Now, see there, these are the common complaints. We have to always ask about the general orthopedic history. Why? What's the problem with you? What is the chief complaint? Is there any history of trauma or not? How your problem started? Okay, those type of questions. And then the typical knee symptoms we are going to ask. And these are locking of the knee, pseudo locking of the knee, painful clicking which is audible, and giving way of the knee. Now, let me explain this point for you. Locking of the knee is a mechanical block to extension. Now, sometimes, people will experience this type of problem. They cannot fully extend the knee. Okay, there is some blocking to the full extension. This is called locking of the knee, and this is very common problem in meniscal tear. Remember those lateral meniscus and the medial meniscus. Okay, they are present inside the knee joint. If they are torn because of a severe injury, then there is a locking of the extension of knee joint. If some loose body is present in the joint, like osteophyte, the broken pieces of osteophyte, then also same problem will occur. Another is pseudo-locking. Pseudo-locking is a limited range of motion without the mechanical block. Okay, it is not the complete blockage, just restriction in the range of motion, and that can be seen in effusion of the joint, muscle spasm after injury, and arthritis. Now, effusion occurs inside the joint because of any injury. Effusion is collection of fluid inside the joint, like infection. Okay, any fracture which is occurring around the joint will cause spasm of the muscle, and arthritis, osteoarthritis, and rheumatoid arthritis are the good example here. Third one is audible clicking in the knee, and that is a painful type of clicking. This is also a feature of torn meniscus. And another one is instability or giving way, okay, of the knee. Now, giving way means, the person cannot hold the extension in a particular, position. Okay, it is sudden extension or sudden flexion. A person cannot, use the knee in that particular position. This is called giving way, and this is a common feature in cruciate ligament rupture, patellar dislocation, or even in meniscal tear. So these are the common knee symptoms. Let's move on. Now, see there. So these are Now, these are the common knee history we like to take in the patient. We just now talked about this. So this is a good mnemonic to remember. CLIPS. The C is clicking, L stands for locking, I is instability of the knee joint, P is pain, and S is swelling. Very good one to remember. So these are the main problems when knee is injured, either because of trauma or because of some other joint disease. Okay. Now, on physical exam of the knee, do not forget to evaluate the hip also, because sometimes the hip joint is also injured as a result of trauma or as a result of some other medical conditions like rheumatoid arthritis, okay, or osteoarthritis may occur in both of the joint. Physical examination is difficult in acute knee injury, so immobilize the leg and re-examine in 1 week time if we are having problem for the examination right now, because sometimes the knee is hugely swollen, it is very painful, so the examination may not be appropriate. Now, let's talk about how to evaluate the knee joint. Okay, when we are examining the patient, how to evaluate the knee. This is mainly a clinical type of discussion, so please pay attention here. The first of them is called anterior and posterior drawer test. Anterior and posterior drawer test. Now, why we do this? This is done to demonstrate anterior cruciate ligament and posterior cruciate ligament injury. Now, how to do that? Let's talk about it. Knee is flexed at 90 degree, okay, just like this, which is shown in the picture. Foot is immobilized and hamstrings muscles are relaxed. We ask the patient to relax the hamstrings. After that, okay, we pull the tibia. We pull the tibia anteriorly. That is called anterior drawer test. And when you push the tibia posteriorly, that is done in posterior drawer test. Now, when it becomes positive, that is important one. If we able to sublux tibia anteriorly, when we are pulling it anteriorly, then anterior cruciate ligament may be torn. After the rupture or tear of anterior cruciate ligament, then only I can pull the tibia in front, or I can move the tibia in front. This is called able to sublux the tibia. So similarly, if able to sublux tibia posteriorly, then posterior cruciate ligament may be torn. So these are called drawer test, very commonly done in clinical practice. Let's move on. Now, another test for the evaluation of the knee is called Latchman test. This Latchman test demonstrates the torn anterior cruciate ligament. Now, it is a bit similar to the drawer test, the anterior drawer test, but there's slight difference here. In this case, we hold a knee in 10 to 20 degree flexion only. Remember, in drawer test, it's almost 90 degree. Okay, so here just 10 to 20. Stabilize the femur and try to sublux the tibia anteriorly on femur. The mechanism is still the same. We do the same type of movement now. We try to pull the tibia anteriorly on femur. So this is similar to anterior drawer test, but it is more reliable, test for the diagnosis of torn anterior cruciate ligament because of less muscular stabilization. So Latchman test is one of the tests we can do for the evaluation of anterior cruciate ligament. So this type of MCQ question can be asked in the exam. So another test we do is called Thessaly test. Now this demonstrates the meniscal tear. So let me underline the very important points only. So it demonstrates the meniscal tear now. Okay, Thessaly test is for demonstration of meniscal tear. We ask the patient to stand flat-footed on one leg while the examiner provides his or her hands for balance, otherwise the patient may fall. So this is just to maintain the balance. The patient is asked to flex the knee to 20 degree and patient is asked to rotate the femur on the tibia medially and laterally. 3 times while maintaining the 20-degree flexion. So this is asking the patient to flex the knee to 20 degree first and rotate the femur on the tibia medially and laterally 3 times each while we maintain that angle. Now, what is the interpretation? This test is positive for a meniscal tear if the patient experiences medial or lateral joint line discomfort while we do this maneuver. Now, what do you mean by medial or lateral joint line now? Isn't it? That may be the new term for you. Meaning is very simple. You just press on the medial side of the knee with your finger and just press the lateral side of the knee with your finger, and if there is tenderness or discomfort, then that is medial or lateral joint line tenderness or discomfort. Okay, there is no proper line as such there. We just push or press on the medial and lateral aspect of the knee joint. So this is Thessaly test. Now another is posterior sag sign. Posterior sag sign. Now what is this? It demonstrates the torn posterior cruciate ligament now. Okay, so in this evaluation, we flex the knee and hips to 90 degree, hold ankle and knees, and view it from the lateral aspect. Okay, so let me repeat again. Flex the knee and hip to 90 degree and hold ankle and knee and then view from the lateral aspect. If one tibia sags posteriorly compared to the other, this means the posterior cruciate ligament is torn because it cannot give support to the posterior sagging of the tibia. Okay, so this is the meaning. Sagging, just moving slightly posteriorly, that is called sagging. Now, what about the collateral ligament stress test now? There are two collateral ligament we have, medial and lateral, and this stress test is done for those ligament damage. So palpate the ligament for opening of joint space while testing. This is important point here. See this? Palpate the ligament for opening up of joint space while testing it. With knee in full extension, apply valgus force to test the medial collateral ligament, whereas we apply varus force to test lateral collateral ligament. Okay. Now, I'm sure you all know what is valgus and varus force. Let me ask that question again. What is valgus and varus? Anyone?
Sir, valgus toward the midline and varus away from the midline.
Exactly. So just the meaning here is we are pushing either towards the midline or away from the midline, just to test whether the medial collateral ligament and lateral collateral ligament are damaged or not. Okay, that's what I want to say here. Repeat the test with knee in 20 degree flexion to relax the joint capsule. Repeat the test again when we flex the knee in 20 degree. And opening of joint space only in 20 degree flexion occurs due to medial collateral ligament damage, whereas opening of joint space in 20 degree of flexion and full extension is due to medial collateral ligament damage, cruciate ligament damage, and even joint capsule damage. So this may be a little bit complicated for you at the time being, okay, but don't worry, nobody is going to ask you these things in detail. Nobody. But what's the point of discussing this here is for the MCQ exam from orthopedics. Just if you catch some of the important points, you will solve those MCQ correctly. That's my objective here. Now, what are the tests for meniscal tear? Now, menisci are present inside the knee joint. So in the meniscal tear, we have joint line tenderness. Joint line tenderness. Just now I told you medial joint line and lateral joint line. We just give a firm pressing there. And if the patient winces in pain, or if they complain of pain during our examination, then probably there is meniscal tear. This is the principle of medicine, surgery, or whatever clinical subject you are learning. Remember always, when you are eliciting the tenderness, always look at the patient's face. Always, okay? Look at the facial expression. Don't only ask, is there pain or not? Look at the patient's face, and that's what we do here also. Another is a crouch compression test. And in this, there is joint line pain when squatting. Anterior pain suggests patellofemoral pathology. Okay, patellofemoral pathology. This is not for the meniscal tear. This is for the patellofemoral pathology. Or if, for example, if some problem occurs in the patellar ligament or ligamentum patellae, then when squatting, we develop pain there. This is known as crouch compression test. Another evaluation or another examination in case of knee injury or knee pathology is called McMurray's test. Just remember, if they ask you, McMurray's test is done in which of the following condition? If you can pick the correct answer, that's more than enough from this discussion. So still, let's talk a little bit about this. This McMurray's test, so let me underline the important point. With knee inflection, palpate the joint line for painful pop or click. Okay, we put the knee inflection first, and we palpate the joint line for painful pop or click, feeling there. Internally, rotate the foot, give varus stress, and extend the knee to test lateral meniscus. And opposite thing we do to test the medial meniscus, like externally rotate the foot, give valgus stress, and extend the knee to test for the medial meniscus. So this is McMurray's test. So there is one picture which is shown here regarding the McMurray's test. This is the examination for medial meniscus tear. Okay, this is the test which is done, and this is for the lateral meniscus tear. So just remember, McMurray's test is done for the diagnosis of meniscal tear. That's it. Now, how to evaluate the knee from investigation point of view? We take X-ray, we take CT scan, or even MRI. MRI is also very commonly used to diagnose the ligament injury. Okay, MRI is the best for the diagnosis of ligament injury. X-ray and CT scans are good to know bony injury. So X-rays are taken in anteroposterior standing position and lateral position, and sometimes we take the skyline view also. This skyline view means it's a tangential view with knees flexed at 45 degrees to see the patellofemoral joint. So from the top surface, from the above, okay, you are taking the X-ray. Now this one, okay, you can do on your own. If it is not very clear, you can refer any orthopedic textbook, any standard textbook, okay, and that will describe the important feature of this cruciate ligament tear. These are a little bit more than what you need at this level, but some of the important points are given here. Okay, so the students, if they are interested, they can go through this. Now a little bit important point from the knee injury again. The partial ligament tear are much more painful than a complete ligament tear in case of ligament injury. Now, after the ligament are torn, after they are completely ruptured, patients surprisingly will not have pain. But if the ligaments are partially ruptured or tear or torn, there is too much pain. Okay, so this is a very important history we need to ask to the patient. And another important point, the mobility is much more free in case of complete tear or rupture of the ligament. Now, there is one important MCQ question for you in the exam, and that is known as O'Donog's unhappy triad. So let me underline that so that when you later on, look at this video or go through this, you can revise this nicely. So O'Donog's unhappy triad means anterior cruciate ligament rupture. Okay, this is medial collateral ligament rupture and meniscal damage, either medial or lateral meniscal damage. So all three important, a part of the ligaments around the knee or inside the knee are damaged here. So this is the important question. Now, if anterior cruciate ligament is damaged and the orthopedic surgeon has planned for the reconstruction, then from where the material is taken now. So these are the tissue sources for anterior cruciate ligament reconstruction. One is from the hamstring group of muscles. Probably the tendon of hamstring group is borrowed there. Another is middle 1/3 of the patellar tendon itself, and third one is the cadaver, okay, from the dead person, and this is known as allograft. Now, what are the other types of graft? Okay, you have studied long time ago, probably in immunology. What are the other examples of the graft? What do you mean by autograft and what is xenograft? Yes, what is the difference from allograft? Anyone?
From that body.
What is autograft means what? Auto.
From one's own body.
Very good. And what is xenograft? What is xenograft? Now, let me explain this because these are the related terms, So make a habit of studying like this and write the important point quickly there. Then you will not forget. So auto means from our own body. One tissue is transplanted to the other. A perfect example is skin graft. For example, this one, hamstring, and this middle 1/3 of the patellar tendon is autograft. Allo means the different member of the same species. If I take a certain graft or certain organ from my brother and sister, this is allograft. Okay, cadaver, that is human being, dead person. This is also allograft. And geno is from animal, from another species, if we are accepting some graft. So these are the important point here. ACL tear is more common than the PCL tear, and MCL tear is more common than the LCL tear. I'm sure everyone know the full form now. This is anterior cruciate ligament and posterior cruciate ligament. This is medial and lateral collateral ligament. Very common in football player. Now, with this, okay, let us enter into the some of the pathology in the remaining 10 minutes time. Now, why collateral ligament tear occurs, what are the clinical feature, and how we manage it. Now, the mechanism for collateral ligament tear, okay, is a valgus and varus force to the knee. Valgus force is needed to injure MCL, and varus force is needed to injure LCL. Okay, so the meaning, if you remember the meaning of valgus and varus, it is quite easy for you to remember this. Regarding the clinical feature, what happens to the patient? There is swelling or effusion of the knee joint. Swelling and effusion because of the same trauma which is occurring to the knee. There may be tenderness above and below the joint line, medially in case of medial collateral ligament or laterally in case of lateral collateral ligament. This is known as joint line tenderness. There is laxity of the joint with varus or valgus force to the knee. Now remember, we discussed about this opening up of knee joint. This is known as opening up of knee joint, or development of excessive laxity. Laxity with endpoints such as partial tear and laxity with no endpoint suggests a complete tear. Now, in complete tear, there is a complete laxity. There is excessive movement or undue movement, which is very abnormal. At the same time, you should test for other injury. Remember that unhappy triad, okay, or Donog's unhappy triad. So you have to examine for other types of injury like meniscal injuries, okay, and cruciate ligament injury as well. At the same time, examine for common peroneal nerve injury. Now, a small question again. Where is common peroneal nerve present? On which side? Anybody?
Around the fibula.
Very good. Around the fibula. So fibula is present where? On the lateral side or medial side? Where?
So lateral side.
Lateral side.
Exactly, on the lateral side. So whenever there is lateral, ligament tear, lateral collateral ligament tear or fibular collateral ligament tear, there is a chance of common peroneal nerve injury because it is encircling the neck of the fibula. So that's a common type of injury in this situation. Now, regarding the treatment of collateral ligament tear, if there is a partial tear, we immobilize the joint for 2 to 4 weeks. After that, range of motion is allowed and strengthening exercise are allowed for the patient. Whereas in complete tear, we immobilize, okay, at 30-degree flexion for a same type of duration. In multiple ligamentous injury, you repair those ligaments. And even in complete tear, it depends on the surgeon. They usually go for the repair. Now, another important part of today's lecture is meniscal tear. And if any question comes from this, okay, most of the time it is from meniscal tear. So please pay attention here. There are 2 menisci inside the knee joint, lateral and medial. We all know that now. And medial meniscus tear is much more common than lateral tear. It is much more common than lateral tear because of the associated injuries there. Now, what is the mechanism? Why menisci are torn or they are ruptured? The mechanism is there is a twisting force on knee when it is partially flexed. For example, stepping down and turning suddenly. Okay, stepping down from the ladder or from the steps, for example, and turning suddenly. This is one of the important mechanism, and it requires moderate trauma in young person, but only mild trauma in elderly people due to degeneration. Now, let me explain this a little bit. This is very common in football player because football player usually, there is a lot of stress to the knee joint. They keep on rotating their knee during the play, and these meniscal tears are very common in them. But if the persons are relatively older, because of the degenerative mechanism, this occurs in all tissues, all organs of our body during the older age. So even these ligament, these menisci are suffering from this degeneration, so they can be ruptured easily. Now, how we diagnose it? What are the clinical features of meniscal tear? See here, there is immediate pain in the knee. There is difficulty in weight bearing. The knee joint becomes unstable, and there is a clicking sound when the person moves the knee. These are important features. There is increased pain with squatting or twisting type of movement. We talked about this just now. During squatting, there is more pain, okay, both in patellofemoral ligament injury as well as meniscal tear. And twisting will definitely increase the pain. There is hemarthrosis inside the knee joint. What do you mean by that term, hemarthrosis? Yes?
Bleeding inside the joint.
Inside the joint.
Exactly. Blood collection inside the joint is called hemarthrosis. This is because of trauma. There is a rupture of some of the blood vessels there, and leads to collection of the blood. This also occurs in so many other conditions. One of the important situation is called, you have studied that in medicine. It's a type of bleeding or clotting disorder. What is that? The same knee joint bleeds all the time in that condition. Yes? Which condition I'm talking about here? Hemophilia.
Hemophilia.
It is hemophilia. Okay. I cannot ignore your answer. In DIC also there may be a chance of bleeding there, but if your examiner asks question like this, they are giving example of target joint. This is a case of hemophilia. Now, why I am connecting to the hemophilia here? Because of hemarthrosis. In hemophilia, that is very common, but here it is because of trauma. This effusion or hemarthrosis occurs, okay, with the insidious onset in this condition around 24 to 48 hours after injury. There is joint line tenderness, medially or laterally. Very important clinical feature. You just press there on the medial or lateral aspect of the knee joint and look at the face of the patient. If they wince, okay, with pain, the tenderness test is positive. And another important feature is locking of the knee. A portion of the meniscus mechanically obstructing the extension, that is called locking of the knee. Or you can simply say locking of the knee is present in case of meniscal tear. Now, what is locking? The person cannot fully extend the knee. The person cannot fully extend the knee. The knee locks before the full extension. This is known as locking of the knee. This is seen in meniscus tear. What about the investigation of meniscal tear? We can go for MRI because these are the cartilage and the damage can be very easily picked by MRI. MRI means magnetic resonance imaging, and even arthroscopy can be done. Arthroscopy are specialized investigation of any joint. It's an endoscopic examination of the joint. So there are two functions of arthroscopy. One is diagnostic, another is therapeutic. Now, when we talk about treatment, you realize what is the therapeutic effect. Now, treatment are, according to the situation. For example, see here, if the knee joint is not locked, then the range of motion and strengthening is preferred. Means we actively, want our patient to move the knee joint. That is called a range of motion or movement, and strengthening exercise. Along with that, NSAID therapy is given because that's a painful condition. But if a knee joint is locked, okay, or failed from above, then arthroscopic repair or partial meniscectomy can be done. This is this use of arthroscopy to repair the meniscus if it is possible. If we cannot repair it, then remove the meniscus. That is called meniscectomy. With this, let's move on. We are towards the end of this big topic. What about the quadriceps or patellar tendon rupture? Now, quadriceps femoris means it's a group of muscle. So which muscles are there in quadriceps femoris? Can you take the name?
Three vasti and rectus
Three
femoris.
vastus and one rectus.
Very
Rectus
good.
femoris.
Very good. Excellent answer. Three vasti and one rectus femoris. Excellent. Vastus medialis, vastus lateralis, vastus intermedius. These are three, and then rectus femoris. So the tendon of all these, vasti and the rectus femoris join with each other, and that is known as quadriceps femoris tendon. It is attached to the upper part of the patella. Upper part of the patella, and from the lower part of the patella, the ligamentum patellae. Okay, we call it ligamentum patellae, or you can also call it patellar tendon. It doesn't matter. Both terms are equally used. It will be attached in the tibial tuberosity. Tibial tuberosity, which is a pointed area on the upper part of tibia on the anterior side. Now, when this patellar tendon or this quadriceps femoris tendon is ruptured or damaged, that's what we are talking right now.
So what is the mechanism of injury? Sudden forceful contraction of the quadriceps muscle during an attempt to stop. The person is running, for example, okay, vigorously, running very fast, and suddenly when the person stops there, okay, for example, some danger comes suddenly in front. During that time, there is vigorous contraction of the quadriceps femoris muscle, and that contraction can rupture the tendon. Another one, in obese patient and some patient who have degenerative changes in the tendon already happened, this rupture is quite easy to occur, okay, especially in obese patient. When they suddenly extend their knee, the tendon may rupture, okay. So it has seen so many times, and it is also common in diabetes mellitus, SLE, rheumatoid arthritis, chronic steroid use, and renal failure and dialysis, okay, uh, because of some changes going on in the tendon. Now, what are the clinical features of patellar tendon rupture? The person will be unable to extend the knee, definitely. That is the function of quadriceps femoris muscle, extension of the knee. So, inability to extend the knee is a very important clinical feature, or unable to weight bear. There is possible audible pop sound there, okay, when the tendon ruptures. Patella may be present in lower or higher position than the normal, and there is a palpable gap above or below the patella respectively. Now see there, where is the rupture of the tendon? It depends on that. If the tendon is ruptured above the patella, okay, then patella will be present slightly on the lower position of the knee joint. And when when the tendon is ruptured below the patella, then the quadriceps femoris muscle will pull the patella upward. So there is a gap felt there. That is the meaning. So we have got some particular term for that. Okay, we'll talk about this a bit later. The knee joint may develop an effusion, means collection of the fluid. Now, regarding the investigation, one is a physical examination. We just ask the patient to straight leg raise. That will be impossible. And knee X-ray should be done to rule out patellar fracture. Otherwise, it's a straightforward diagnosis. Now, treatment. The non-operative treatment for incomplete tears with preserved extension of the knee. The incomplete tears, we just ask the patient to take rest actually. It will be all right. So this is non-operative treatment, okay? And we ask the patient to preserve the extension of the knee. Means most of the time the person should extend the knee. Then NSAID therapy will be given. That's enough. Surgical repair of the tendon is indicated for complete rupture, isn't it? There's no other way. We need to suture the tendon because it is completely separated from each other. Early surgical repair has a better outcome compared with a delayed repair. Delayed means more than 6 weeks post-injury. Some patients are like that. They don't come to the hospital. They take it very easily. They think the bone is fractured or something like that, and it takes time to heal. So they don't report to the hospital. That doesn't have a good prognosis. And delayed repair are complicated by quadriceps contracture, patella migration, either inferiorly or superiorly, and development of adhesions between the patella and the femur. Okay, so these are some of the problems in case of patellar tendon rupture. Now let's move further. Now let's talk about a dislocated knee joint. Now this dislocation of the knee joint is not a very important question in the exam. Okay, we prefer to ask about shoulder dislocation and hip dislocation rather than this. But nevertheless, let's talk something about it because this is a related topic here. Mechanism of dislocation of the knee would be high energy trauma because this is a strong joint. Okay, this is a modified type of hinge joint, And what are the components of this knee joint? Let me, hear the answer once again. The components of knee joint, what are those? How knee joint is formed?
Tibiofemoral ligament and patellofemoral.
Good, good. So this is tibiofemoral, okay, articulation, and patellofemoral articulation. Articulation is a joint. This is another term. So this is a bit of complicated joint, a compound type of joint. So that's why we need a high energy trauma to dislocate it. And it is dislocated only if tears of multiple ligaments occur in the knee joint. Now let me ask, what are those ligaments once again? Just take the name of those ligaments which are making the knee joint stronger. Yes, what are those? What are those ligaments?
Collateral ligaments,
Interior collateral ligament, lateral collateral, interior
collateral ligaments,
and posterior cruciate ligament.
cruciate ligament.
Very
Lateral
good.
and medial collateral ligament and cruciate ligament.
Lateral menisci.
Very good. So many, students are answering it. Excellent. So the main important ligaments here are collateral ligament, collateral, which are on the side, lateral collateral ligament and medial collateral ligament, and cruciate ligament, which are present inside the knee joint. Cruciate, anterior cruciate ligament and the posterior cruciate ligament. Okay. The meniscus is not making the knee joint stronger. It is actually acting as a shock absorber, though it's a part of the knee joint, and it is a type of cartilage. It is not a ligament. Remember this. And one more, you can take the name of that also, like a patellar tendon. Okay, patellar tendon. It is also making that knee joint relatively stable. So if these ligaments are ruptured or damaged, then there is a chance of dislocation of the knee, which happens in severe type of trauma. Regarding the clinical features, let's talk about it now. There is, okay, knee instability or dislocation or subluxation. Now, according to the relation of tibia with respect to the femur, the dislocations are termed as anterior, posterior, lateral, medial, and even rotatory. It depends. Where is the upper part of the tibia in respect to the femur? Okay, so this is about the type of dislocation of the knee joint. Another is effusion, usually blood. Pain is very severe, and if blood vessels are damaged, there is a ischemia of the limb. So which blood vessel has the high chance of damage in case of dislocation of the knee? Which blood vessel? Yes?
Popliteal artery.
Popliteal artery.
Excellent. Excellent. This is popliteal artery, okay? Popliteal, because femoral artery is already converted into popliteal artery now. It's the same artery which is continued actually, but we call it popliteal artery at that area, popliteal fossa. So that artery can be damaged by dislocation of the knee. Let's move on. Now, regarding the investigation, we can take X-ray, AP view, lateral view, and skyline view, means the X-ray beams are passed from above. Now, the radiography may show some associated fractures, okay? Associated fractures if they are present there. That is an extra advantage of taking X-ray. And if fractures are associated with dislocation, we call it complicated type of dislocation. One of the important, point here, which we like to highlight, is ankle brachial index has to be measured, and if it is less than 0.9, it is abnormal. Now, this may be a new term for you. So what is the meaning of this ankle brachial index? So let me explain this. To measure this, or to take the ratio of ankle brachial index, you need to take blood pressure of lower limb. Okay, blood pressure of lower limb. Need to take blood pressure of the upper limb. And then take the ratio. That's it. Blood pressure of the lower limb is taken, Then blood pressure of the upper limb is also taken, and we take the ratio. If this ratio is less than 0.9, that means there is presence of peripheral vascular disease, or there is ischemia of the lower limb. That is the interpretation. So this type of question can be asked to you. Okay, this type of test can be done in any suspected case of peripheral vascular disease, not only here. Now, why here? Because there is a chance of popliteal artery damage. When popliteal artery is damaged, then there is decreased blood flow towards the leg area or the foot area. So this test is a relevant one here. Another investigation we can go for is arteriogram or CT angiogram. Again, if abnormal vascular examination is found. This is also done to know how much blood is flowing there. What is the state of the arteries there? Okay, so this is another type of investigation. Now, there are some important terms here according to the location of patella. So if the patella is lying quite high, okay, than its normal position, we call it patella alta or high riding patella. If patella is lying inferior or distal to its normal position, we call it patella basa or infera. Patella basa or patella infera. Infera is a good term, isn't it? It's very easy for you to understand also. This is known as low riding patella. So this type of question sometimes can be asked in the exam. What is the treatment then? What's the treatment of dislocated knee? Now, just like any other, treatment of dislocation of the joint, we have to do urgent close reduction of the knee joint as well. Urgent close reduction. Close reduction means you don't open it. It's not a surgical procedure. But one problem is it may be complicated by interposed soft tissue. There are different types of ligaments present inside the knee joint. You all know that, like the cruciate ligament are present inside the knee joint. The menisci, those cartilages are present there. So they may, interpose while we do the reduction. Assessment of peroneal nerve, tibial artery, and ligamentous injury has to be done. We always do this. This is known as neurovascular injury assessment. Repair of associated injury is done. Okay. We also may need decompressive fasciotomy, especially if vascular repair is undertaken. Now, let me explain this a little bit, though students already know. Fasciotomy is a cutting of the deep fascia of the leg area. Now, why? If this artery is damaged, okay, the popliteal artery, then there is ischemia of those muscles which are present in our leg area. If those muscles are ischemic, remember, there is development of compartment syndrome. So to treat that compartment syndrome, or to prevent from the compartment syndrome to develop, we can go for fasciotomy. That is the meaning. Knee is immobilized for 6 to 8 weeks after we do close reduction. Now, what are the specific complications of dislocation of the knee joint? Let's talk about this. Now, see there, this is a very important question. But if you use your common sense, these answers are quite easy now, because you have done most of the part of traumatology already. There is a high incidence of associated injury in the dislocation of the knee, like a popliteal artery tear. Okay, we know this now. Peroneal nerve injury. This is a common peroneal nerve injury. It is right there near the neck of the fibula. There may be capsular tear, capsule of the knee joint, and there may be instability of the knee joint after it is dislocated if it is not treated properly in time. There may be stiffness of the muscle which are surrounding the knee joint, especially the quadriceps femoris, and there may be a chance of post-traumatic arthritis. This is osteoarthritis, which may develop later on. And remember, osteoarthritis is a painful condition of the joint. It is known as degenerative changes, development in the joint. So the person will have problem, most of the time in the later life. So these are the specific complications. Now, I have moved to the last part of this big topic, that is knee injury. So let's talk a little bit about fracture of the patella. So in clinical practice, patella is also commonly fractured. Now, this is the patella. Patella is a type of sesamoid bone because it develops inside the quadriceps femoris tendon, and it is the biggest sesamoid bone in our body. What are the causes of patellar fracture? The causes can be direct forces, direct injury, severe type of injury directly to the patella can fracture it, or indirect forces like there is strong contraction of quadriceps femoris muscle. Patella is present inside the tendon of quadriceps femoris. Okay, we all know that. So the quadriceps femoris tendon is attached at the upper part of the patella, and from the lower part of the patella, then the ligamentum patellae will be inserted in the tibial tuberosity. So if there is a vigorous or strong contraction of the quadriceps femoris, okay, the patella may be fractured right in the middle. So this type of cases have been seen. Regarding the classification, look at this picture. Okay, it is explaining itself. Transverse fracture, upper pole fracture, lower pole fracture, and the burst fracture, also known as stellate type of fracture. So here, this is a transverse fracture, but it is undisplaced. It is a transverse fracture which is displaced. Okay, this is a lower pole fracture. Okay. Lower pole fracture, or similarly, upper pole fracture may also be there. This is a comminuted fracture which is undisplaced because it has not moved from its original position. This is a comminuted displaced fracture. So see that there is a considerable gap between each of the fracture segment. This is a vertical fracture, and this is an osteochondral fracture. Okay, osteochondral, a little bit of cartilage is also affected. Now, regarding the pathoanatomy of patella fracture, it may remain undisplaced or displaced. Now, it may remain undisplaced because of the intact pre-patellar expansion of the quadriceps tendon in front and patellar retinaculae on the side. These patellar retinaculae are the fibrous band which are making that patella stable from the side. So if they are not ruptured or not damaged, then patella may not displace on the lateral side. Or if the quadriceps tendon is still intact, then it may not be displaced. Whereas it is displaced if quadriceps contraction is strong enough and if there is a tearing of patellar retinaculae. So this is the reason for undisplaced or displaced type patellar fracture. Now, how to diagnose? It's a straightforward case. How to diagnose it? Very easy. Pain and swelling over the knee. Clear-cut case because there's a fracture of the patella which is present right there. The crepitus is felt in a comminuted fracture. Crepitus is a sound, okay, when two bones are frictioned against each other. That is a crepitus sound or crepitus feeling. It is better felt than the heard. If it is a displaced type of patellar fracture, the gap is felt there. Okay, we can feel the gap between the fragment because of the displacement. Knee joint cannot be extended fully because that is the function, okay, of this whole apparatus. This is called extensor apparatus of the knee joint. Extensor apparatus is formed by quadriceps femoris tendon, patella, and the ligamentum patellae. So if any one of them is ruptured, knee cannot be extended fully. Bruises in front of the knee because of the soft tissue injury, and there is hemarthrosis as well, blood collection inside the knee joint, or knee joint is swollen. Now look at the X-ray, how to diagnose it. Of course, X-ray will be done, okay, AP and lateral view and skyline view is necessary sometimes just to make sure you see the fracture line properly. Now see that There is a fracture line here. I can clearly see it. This is a transverse type of fracture right in the middle. Now, what's the treatment then? In case of undisplaced fracture, the different type of treatment is done. In case of displaced fracture, different treatment is done. Now, see here, in undisplaced fracture of the patella, we put cylinder cast. The cylinder cast is the plaster cast which extend from the groin to the just above the malleoli with the knee in full extension for up to 3 weeks. So this is a long cast which is applied from the groin area, okay, or the inguinal area you can say, and it will reach just above the malleoli. So the whole of the thigh, okay, knee and leg are included inside the cylinder cast. And the knee joint should be in full extension, okay, up to 3 weeks. In case of displaced fracture, we go for surgery. That is done by tension band application, circular tie application, and patellectomy with repair of extensor reticuli. Patellectomy is the removal of the patella, probably in case of severely comminuted fracture. Okay, we have to go for patellectomy. But after that, we need to repair the extensor reticuli or extensor apparatus. Otherwise, the person cannot extend the knee joint later on. Let's move on. Now look at this. Okay, so see here, this is the fracture patella, and here is the surgical treatment. See that the wire, this is a wire therapy, and there are some pins also inserted. Now finally, regarding the complications of patellar fracture, there is a stiffness of the knee. If the person doesn't actively going for physiotherapy, then knee stiffness is very commonly happening. So physiotherapy plays a big role there. Extensor weakness, quite logically, because patella is a part of extensor apparatus of the knee, and later on there may be osteoarthritis that can develop if it is not reduced properly, or if the fracture is not treated properly in time. Okay, so with this we have done all of the fractures of the upper limb and the important fractures of the lower limb.